Good afternoon, everybody. We are about to start the afternoon session, so I kindly ask you to take your seats. So, if you want to start in English.
Good evening. My name's Stephen Stowers from New Zealand. I have the pleasure of introducing my colleague from across the ditch, Nathan Better, cardiologist and deputy director of nuclear medicine at the Royal Melbourne Hospital. We'll talk about clinical case demonstrating the challenges he faces in Australia.
Thank you very much, Stephen. And this is my second talk today. But once again, just for those that didn't hear my first one, I just wanted to say thank you again to the organising committee for the invitation, to João Vitola particularly. And I really am in awe of your country, how beautiful and how hospitable everybody has been, particularly here in Curitiba. In Australia, we have many problems, as do places in the world. And I've only got 12 minutes, so I have to choose one thing specifically to talk about. We have issues with our reactors breaking down and the supply of technetium-99m. We have competition with stress echo and with CTCA, not with perfusion MRI yet. We have issues with calcium scores that there's a general rule they are not reimbursed unless they're done with MPI or myocardial perfusion imaging. Like everywhere in the world, we have issues with engaging our referrers, problems with the radiation dose, which has been addressed in INCAPS 1, but still only 36% of our studies are below the desired 9 millisieverts at the moment. And hopefully this is something that will improve to be evaluated during INCAPS 2. And like with a lot of places, research funding is difficult. Culturally, we have a lot of similarities with Brazil, and as I mentioned, I've fallen in love with your country. We have our own flora and fauna, but yours is spectacular. This is mine. This is yours, the toucan busy at work in this native environment. This is the Uruguayan nuclear cardiologist busy at work in his native environment. It's a joke slide. Let me present my one clinical case today. I'd like to talk about a 65-year-old male, has a positive family history, hypertensive, LDL cholesterol of 4.8, so markedly elevated, is diabetic, the royal flush of risk factors. Presents with chest pain for investigation, exertional but pleuritic and atypical. Examination was normal apart from hypertension, and the ECG showed sinus rhythm with a left bundle branch block. So, everybody has to wake up now. We're going to have a show of hands. Let's vote. Who does nothing for this patient? No handers. We're all interventional cardiologists or imaging cardiologists. Who's going to do an exercise ECG? Clearly not the right answer with a left bundle branch block. A stress echo? 1 or 2 people. This is going to have problems that you are going to have a septal defect at rest, which is going to make LAD ischemia very hard to interpret. What about a stress nuclear for this patient? All the hands are going up, and this is where stress nuclear is at its best. Cardiac CT, few hands going up, not unreasonable, and a coronary angiogram, clearly not the right test because you will find coronary disease, but you're not sure whether this is actually the problem. If you're going to do an MPI, we have a choice, either exercise or pharmacological. In my country, we have no regadenoson, so you have to use dipyridamole or adenosine or dobutamine. Who would do exercise? Who would do pharmacological? A show of hands. Exercise? Pharmacological. And the pharmacologicals are correct because with the left bundle branch block, we'll get increased artifact if you do exercise and get the heart rate up over 100. So we did a dipyridamole stress sestamibi study, off caffeine for at least 24 hours, with a traditional protocol. The patient had a normal hemodynamic response, no pain, a non-diagnostic ECG, and I'm going to show you now the rest and the stress imaging, the gating, and also the images from CT attenuation correction. As you can see here in the second, fifth, and 8th rows, we have the stress images. In the 3rd, 6th, and 9th rows are the resting images. And in the top view are the CT attenuation corrected slices. What one can see here is that there is an inferior wall defect at stress and at rest, and with CT attenuation correction, it's disappeared. Who says normal? Who says abnormal? Normal? Abnormal. And one or two hands going up. The feeling is this is actually a normal study. With CT attenuation correction, the defect has disappeared and the study is normalized. Here we can see the quantitation, it's normal. The LV function at stress and rest was also normal. 10 years ago, this is where we stopped. Now, we do more than just reassurance. We start to look at our images. So we start to look at our different structures from the CAT scan. And what one can see here nicely is there's lots of calcium in the circumflex artery and in the LAD. We know from data, and presenting a little bit about calcium scoring, that as the calcium scoring goes up, from less than 100 to greater than 400, the chance of a cardiac event increases dramatically. And the 15-year impact increases the risk by a factor of ×9 if your calcium score is over 1,000. So we're not only saying that this patient does not have ischemia, we are now saying that this patient has non-obstructive coronary disease, which is going to add to the risk of the patients. This is my favourite slide of all time. This study by Elmesik's group, published in Circulation Imaging, looked at calcium score, which quite appropriately, as the score goes up, the event rate goes up. But as you differentiate between a normal and an abnormal SPECT, there is a difference in the risks. Not surprisingly, if the study is abnormal, you're going to get a higher cardiac event rate. The two most fascinating things about this slide is that if your calcium score is 0, whether your SPECT is normal or abnormal, your prognosis remains excellent. Conversely, if your SPECT is normal and you have a very high coronary artery calcium score, you have an event up to 5% per year. So this is stuff where you have to deal with on a preventative basis. We also look at other structures. And we know here that when you look at this study presented by Zadro's group in Journal of Nuclear Cardiology, looked at 1,500 patients and found that over half of them had minor extracardiac findings. And in 14% of cases, this was significant. We published this article in the Journal of Nuclear Cardiology this time last year, and we found a patient here with this hotspot, which worked out to be a carcinoid tumour at the end of the day. So there's lots of fun things you can find when you look at other lesions on the CT images. Importantly, we all try to live for a long time, but the cost of this still remains high, but still very popular. So let's talk about the management for this patient. Large amount of non-obstructive coronary disease. We're going to vote very quickly. Who's going to do nothing? Nobody. Who's going to start the patient on a statin? Up go the hands. Target LDL less than 1.8 or greater than 1.8? Who says high intensity? Who says low intensity statins? Probably the highs win it, probably. Who'd put this patient on aspirin? Few people, hands go up. Very controversial now with the recent data. Who'd cath this patient? This is going to be very interesting. I'm going to show you a slide for this. I wouldn't cath the patient. Who would recommend exercise for this patient? Do lots of exercise. Students putting their hands, nodding in the front in the room. Who would recommend exercise? Yes. Does it help? Let me show you in my last couple of minutes. Coronary artery calcium has been around for a long time, and my friend ABDEL in the front row, who will be talking later on, presented this lovely data from Egypt. And here's one of the first mummies showing calcium in the LAD. So it's been around for a long time. The MESIS trial, was published in 2010, shows that as your calcium score goes up, up goes your cardiac event rate, up goes your incidence of coronary artery disease. In Australia, we've published some guidelines over the last couple of years, looking for patients here that have low risk, medium risk, and high risk. The calcium risk is particularly suited for the calcium score in isolation is particularly suited for patients who are medium risk. Some patients with high and low risk may also benefit, but it's those intermediate risk patients that we really want to target. This is for independent calcium scoring in the absence of MTI. And depending on the calcium score, you may do nothing, recommend diet, recommend statin, or recommend statin plus aspirin. And these goalposts are moving as we speak. I love this trial, which was published in JACC Imaging a couple of months ago, I should say. What they did was looked at 13,000 patients, and they found that statins reduced cardiac events, particularly if the calcium score was over 100. If the calcium score was 0, it made not much difference. But what was really interesting was this group here with a calcium score of 0 to 100. No significant difference between the two groups, but you can see that those two curves are diverging. And I bet my bottom dollar that what's going to happen in about 10 years' time, that this is going to become statistically significant. And in my own clinical practice, I'm using this data to start statins at low calcium score in the absence of guideline recommendation. And recently published in the JAMA Network Open, shown great impact of calcium scores in patients less than 50 years. The Scott Hart study, which was published in August 2018, showed the first study that found that CTCA actually improves prognosis, comparing patients who have CTCA versus CTCA plus standard care. It made a big difference. Why did it make a difference? It all comes down to calcium scoring. And here, Michelle Williams' original work showed that if the CTCA was abnormal, they were more likely to get statins, more likely to get aspirin, more likely to improve prognosis. This trial, nobody put their hand up to cath the patient with a lot of coronary artery calcium, but normal myocardial perfusion imaging. This trial from the Japanese group published earlier this year looked at patients with calcium score, and as the calcium score went up, in the presence of a normal SPECT, you were more likely to get a coronary angiogram by a factor of actually 10% of patients. Will I cath this group? I probably wouldn't. But what this is telling us is that our referring doctors are looking at the calcium score and it's guiding their judgment towards more aggressive therapy, rightly or wrongly. Everybody put their hand up to say exercise helps. And this lovely article from Arnson's group in JACC Imaging has shown that the impact of moderate versus low-level exercise is greatest if the calcium score is over 400. Interestingly, if the calcium score is 0, exercise makes no difference. And in the intermediate group, it's somewhere in between. But the worse your calcium, the more you benefit from exercise. And I'm using this to tell my patients. So in conclusion, my colleagues, in Australia, we still have our problems. Reactors are breaking down. We have to worry about stress echo and CTCA versus nuclear. We talk about reimbursement with calcium scoring, which costs 250 to 300 Australian or $200 US, and versus comparison with reimbursement, which does occur with MPI. We have to engage cardiologists. Problems arise within a country. There's regional variability and test selection. But at the end of the day, you just have to bid for the right test. And the sound has gone off here. I don't know if there's a sound.
600 000 siellä herra, 700 000 puhelimessa, 800 000 rouva, 900 000 puhelimessa, 1 000 000 siellä herra. Tuleeko muita tarjouksia? Ei tule. 1 000 000 ensimmäinen, 1 000 000 toinen, 1 000 000 kolmas.
Thank you for inviting me.
So thank you, Nathan, for the excellent presentation, and we will keep the bet, no? How much did you say, 1 million? So
Just
we
1
will keep
million.
it for you. So our next speaker is my pleasure to introduce Dr. ALIA ABDEL FATTAH. Ela é la chefe do Departamento de Cuidados Críticos da Universidade do Cairo, no Egito, e é consultora de cuidados críticos no Ministério da Saúde do Egito. Foi também vice-presidente do Hospital CARS, CARS El Aini, Hospital Público da Universidade do Cairo. Ela trabalha ativamente na Sociedade Egípcia de Cardiologia. ALIA.
Dear Chairman, dear colleagues, thank you very much for the introduction. And I have to thank the organizing committee and our dear friend Joao Vitola for the nice invitation in your lovely country, Brazil. Definitely I have to thank all of you for the spirit and the friendly spirit that we faced here in Brazil. Let me start my presentation. I'm talking today about the role of the myocardial perfusion imaging, how it's dictating the management strategy in patients with CED. Our patient today is 50 years old patient. He's known to be a smoker, Current complaining of chest pain on mild effort, no history of diabetes or hypertension, and he has history of 2 ischemic attacks, myocardial infarction in 2016 and 2018. Clinical assessment is unremarkable. His ECG, as you can see, here there is inferior evidence of inferior infarction and anterior as there is Q up to V3. Echocardiography revealed dilated left ventricle with poor ejection fraction. It's 28 with extensive regional wall motion abnormality. Left atrium is dilated. And the patient supposed to assess the myocardial viability, whether this patient needs revascularization or just leave the patient on medical treatment. Therefore, the patient was sent for myocardial perfusion imaging. We could do pharmacologic stress, like my dear friend Nathan. We use pharmacologic stress using dipyridamole as a stressor. And here, his myocardial perfusion imaging. We have 2 perfusion defects involving the anteroapical anterior. And here it's quite evident, the anterior anteroapical and anteroseptal segments in stress. And look to the rest study. There is partial filling in the anterior wall and anteroseptal segments. Look to the other perfusion defect in the inferior wall here, inferior, posterior, infralateral, posterolateral, and even in the basal segments involving the lower septum. And how it's coming back. Look to the inferior wall, it's filling in here in the rest study. Also, we have ischemia in the infralateral and posterolateral segments in LCX territory. Black and white, maybe the reversibility is more obvious. And here is the polar maps demonstrate how the perfusion defects is extensive here in the LAD territory, and the apex and the part of the anterior wall, it's almost scarred. This is the stress, and this is the rest. But here in the anterior basal segment of the anterior wall and the anteroseptal segment, there is reversibility here in the LAD territory. Look to this very dark blue color. It's almost no perfusion in these segments during post-stress. During rest, there is marked filling in of this perfusion defect. It means that all these segments are viable. Again, the infralateral, posterolateral showed severe marked reversibility, explaining that this reversibility map, the patient has extensive viable myocardium. Once he has extensive viable myocardium, so this patient justified revascularization. What about his coronary angiography? As you can see here, the patient has total LAD and total LCX. Here in the spider view, total LAD and total LCX. But there is retrograde filling in LAD. Here is the RCA proximal occlusion of the RCA, again, total occlusion, but there is antegrade and retrograde filling. With this anatomy, the patient needs revascularization. The main recommendation was to do CABG, but the patient was young, 50 years old, and he was refusing CABG. And the surgeons were reluctant to do the patient due to the high risk and high mortality rate. So the other option is to do multiple PCI, but it's high risk. During the inflation of the balloon to do the procedure, the patient might have complete cessation of the circulation. Therefore, consensus was done to have revascularization to the LAD, RCA, but with backup of ECHMO. What's ECHMO? VA ECHMO, it's veno-arterial ECHMO. ECHMO, we know that it's a recent form of circulatory support. It's the idea that we have to drain blood from the femoral vein to pass into the ECHMO circuit. ECHMO circuit is formed of the centrifugal pump, and then there is oxygenator containing membrane. We are going to see the details of this parts. Here is the centrifugal pump. It can work up to 21 days. It can deliver up to 8 liters per minute. Here is the membrane, the oxygenator membrane, which is a very important part of this circuit. And it's heparin coated. It eliminates CO2, and it adds oxygen to the blood. The duration, again, 21 days. Here is the console, and it gives all the time displaying the cardiac output, the stroke volume, the temperature, the central saturation, all the parameters, all the time it's continuously displayed. And here these are the cannulas that we are using. The long one, it's the femoral vein cannula, what we call the drainage cannula. And the shorter one, it's the arterial cannula we inserted into the femoral artery. Here is the tubing system that connects the cannulas to the ECHMO circuit. VA ECHMO, it can be used in all kinds of cardiac dysfunction, whether right or left. But now the recent application in high-risk PCI procedure due to its support to the circulation during the procedure. ELSO registry, ELSO, it's the International Society dealing with the ECMO activity all over the world, and in the registry of the whole countries that are attached to the ELSO, 41% survival of patients discharged on when they put on ECMO due to cardiac reason. Here is the idea that we take the femoral vein drainage, blood pass into the pump, and the pump is pumping blood here in the oxygenator. As you can see, here in the oxygenator, the membrane is eliminating CO2, and it's connected to the air and oxygen source to blend the air and oxygen with blood. So the blood coming out is oxygenated, and it will be pumped back into the femoral artery. So here there is pumping of blood into the arterial circulation. This will compensate for the low function of the left ventricle. Here is the femoral vein, femoral artery cannulation, and here what we call the reperfusion cannula to prevent the ischemia to the lower limb. Settings, definitely we have to use the anticoagulation. Advantages, as we all know, it's low cost, rapid implantation, and it can be giving us high stable output. Here is during the procedure, advancing the cannula, and here they're trying to connect the tubing system to the cannulas, red to red, blue to blue. This is how it's connected before starting the intervention, before starting the PCI procedure. Here they started the procedure after establishing the echo, started by the RCA, and you can see the patient had tight lesion in the RCA, and the PCI went very smooth with very good result and complete opening of the RCA, which is very big artery. When they started to revascularize the left system, the passing wire in the LED, the patient started to have hemodynamic instability, but immediately the patient had VTAC, manipulation of the wire. The hemodynamics didn't deteriorate. There was backup of ECMO, giving support to the circulation, maintaining the cardiac output to the whole body. Therefore, the hemodynamics were maintained until successful revascularization to the LED was achieved. And the patient, we could get out of the cath lab with successful, as you can see here, LED is open totally with good result. Then we did decannulation and separation from the ECMO, and the removal of ECMO system, stable hospital course. After 10 days, we repeated echocardiography, and it was 48% instead of 28%, and the patient discharged home, resumed activity. Then 3 months later, he came complaining of chest pain. So MPI was requested to evaluate the coronary perfusion status. This time, he could exercise according to Bruce protocol for 9 minutes and 32 seconds, his ECG, resting ECG, and he could achieve 80% of the maximum predicted heart rate. The cause of termination was fatigue. As you can see, no dynamic changes in ECG, and look to his perfusion study. Let us compare the perfusion, the polar maps before the intervention and after the intervention. Look here to the post-stress, how the perfusion defect was big, and how the perfusion was impaired in LED and RCA territories. Look here, post-stress after the revascularization, very well revascularized myocardium in LED and RCA territory. So the patient was put on maximum or optimization of the medical treatment was the decision, and he was maintained on aspirin, clopidogrel, statin, ACE, nitrates, and beta blocker. Thank you.
Thank you so much, Dr. Alia. Now we are going to Italy. And this time our speaker is Professor Raffaele GIUBBINI. Raffaele è professor titular da medicina e cientista na Universidade de Brescia. É o diretor do Departamento de Imagem no Hospital da Universidade Ospedale Civile na Itália. E os principais campos de interesse dele são pesquisa no campo do fluxo do sangue no miocárdio, perfusão do fluxo coronário e aplicação clínica de PET em cardiologia. Então, o professor GIUBBINI ele vai apresentar o caso da interesse na Itália.
Thank you, Diana. Dear Chairman, dear colleagues, let me first to thank my friend Joao Vitola and the organizing committee for the invitation to this excellent, very interesting meeting. This is my conflict of interest disclosure. I will not touch the topic of ischemic heart disease, but of hypertrophic cardiomyopathy. You know that hypertrophic cardiomyopathy is a syndrome with similar clinical presentation, symptoms, and anatomical features, but different etiologies. The phenocopies of hypertrophic cardiomyopathy include genetically determined sarcomeric mutation that is responsible of 60% of the disease, interstitial deposition of fibers like cardiac amyloidosis, lysosomal deposit to the abnormal function of the galactosidase enzyme, like Anderson-Fabry disease, glycogen storage, mitochondrial cytopathy, and finally, hypertensive cardiomyopathy, the athlete heart, and the inflammatory disease related to sarcoidosis. And what is the role of nuclear imaging, of molecular imaging? The identification of specific phenocopies, the evaluation of coronary microcirculation impairment, and diagnosis and follow-up of inflammatory diseases. This is a case of a already diagnosed Anderson-Fabry disease. You see the severe hypertrophy of the ventricle with almost complete occlusion of the left ventricular cavity and the systole. And this is the T1 mapping in magnetic resonance. You know that the threshold of between normal and abnormal results depends on the characteristics of the single MR equipment. In our hospital, we use this MR, and the blue color corresponds to the a threshold lower than 1,000 milliseconds. That is specific for Anderson-Fabry disease. And furthermore, you see late gadolinium enhancement that is, again, an index of myocardial impairment. This is the evaluation of myocardial blood flow and myocardial flow reserve by ammonia PET. You see, this is the REST study in short axis, horizontal long axis and vertical long axis. After regadenoson induced hyperemia and at rest. You see at rest the severe hypertrophy and maybe also an ischemia of the papillary muscle. And you see that the stress myocardial blood flow in milliliter per minute per gram of tissue is quite low. The normal value is above 1.7, and the myocardial flow reserve is reduced. The threshold, the low threshold is 2. Well, let's go to the clinical case. This is a 52-year-old lady with hypercholesterolemia, hypertension on therapy. She's a smoker, admitted to the cardiology department due to dyspnea and atypical angina. And the invasive coronary angiography, as you can see, didn't show any significant coronary lesion. The patient was sent to the nuclear lab to evaluate the microcirculation, and you see that during regadenoson infusion, we observe a ischemic downslope in the lateral leads. And this is the result of the ammonia PET-CT. There is a severe impairment of hyperemic blood flow and almost no myocardial flow reserve. Therefore, this was an indication to do magnetic resonance. You see that the left ventricular function is normal. There is some level of hypertrophic cardiomyopathy, but the T1 mapping was absolutely normal. And you see in the inferior wall a gadolinium late enhancement, but not considered specific for Fabry disease by the referring radiologist. So we have a patient with a microvascular disease and late gadolinium results, and on the basis of PET result, the patient was evaluated in order to exclude the Fabry disease. She was negative for the enzyme assay for alpha-galactosidase, but positive at molecular genetic analysis of the GLA gene. Therefore, the conclusion was Anderson-Fabry disease. And what is the take-home message? The coronary microvascular dysfunction is an early feature of cardiac involvement in patients with Anderson-Fabry disease. And it can precede the appearance of magnetic resonance specific sign. You see that there is no difference between gender and between patients with and without left ventricular hypertrophy. And this sign, the presence of microvascular dysfunction, can be considered as a trigger to start with the replacement therapy, independently of the presence of severe myocardial hypertrophy. This is another, I have 3 more minutes, so this is another case study, just one slide. This is late gadolinium enhancement, left ventricular dysfunction, and high uptake of this tracer. This is not a perfusion tracer, but this is a bone-seeking agent. When you have these imaging features, the diagnosis is clear, is the fingerprint of amyloidosis related to transthyretin mutation. And in this case, there was a wild-type transthyretin mutated amyloidosis. This is a characteristic image with this sign. The diagnosis is clear. Finally, my last slide. This is a case of cardiac sarcoidosis. There is a inhomogeneous uptake of F18 fluorodeoxyglucose by PET-CT. And this is a high uptake after 72 hours low carbohydrate diet in order to increase the glutathione 1 transporter that is typical of the inflammatory cells and inhibits the glutathione 4 that is specific of myocardial metabolism. And you see a high level on the inflammation, but this is useful for diagnosis. But it is even more useful to evaluate the results of steroid therapy. And after 2 months of steroid therapy, they have a complete normalization of a myocardial uptake of FDG. This is my last slide, and thank you for your attention.
Muito obrigada, professor GIUBBINI. Agora a gente tem o último palestrante, o Dr. Fernando Much, da Uruguai. O Fernando estudou medicina na Universidade de Uruguai e após fez pós-graduação em pesquisa clínica na UCLA, da Califórnia. É estudioso da fisiologia cardíaca e da estratificação do risco e publicou inúmeros artigos em múltiplos journals. Fernando tem especial interesse na conexão cérebro-coração. Então, Fernando.
Thank you, Diana. Obrigado. Muito obrigado pelo convite, especialmente muito agradecido ao Dr. Vítola, uma excepcional organização. Tratamentos convidados foi excelente. Eu vou falar um pouco de portunhol, se vocês aceitam, e com bastante sons afortunados vão conseguir compreender alguma coisa e posso incluir alguma coisa em inglês. Primeiramente, eu quero agradecer ao Dr. Nathan Better por ter essa consideração comigo de haver tomado uma fotografia. Mas eu tenho que dizer que eu sou bastante mais gentil que ele, porque eu também tomei uma fotografia dele, mas decidi não mostrar.
Por acaso, não?
Então, vamos lá. Nós estamos todos apresentados, mas não sabemos muito de vocês. Quantos de vocês são cardiologistas em formação? Residentes? Cardiologistas já trabalhando como imagenólogos? Nucleares? Ok, está bastante misturada.
Estudantes de medicina.
Medical students, estudantes? Ups, bastantes. Tá. Então, possivelmente não seja muita utilidade esta apresentação, que é um caso da prática corrente diária em um laboratório de medicina nuclear bastante movimentado. Mas alguns dos problemas que se apresentam aqui vocês vão enfrentar no futuro, provavelmente, dependendo de qual seja a especialidade que vocês escolham. Então, este é um caso de um paciente de 67 anos, uma mulher com fatores de risco cardiovascular, é uma diabética insulino requerente, com bom controle de sua diabetes, tem sobrepeso e hipertensão. E tem uma dor anginoso típico de classe funcional 2 com disneia. E esta sintomatologia acrescenta nas últimas 24 horas, por esse motivo ela consulta. Se toma este traçado eletrocardiográfico em condições de repouso, é bastante inocente, não tem muita alteração. A paciente foi submetida a um estudo de perfusão miocárdica de estresse e repouso com cestamib. Quantos de vocês pensam que este estudo está bem indicado? Levante a mão, está bem indicado? Mal indicado? E se não está mal, não está bem, que está, ninguém levanta a mão. Vocês pensam que está bem indicado o estudo clinicamente ou que não é necessário de fazer? Seria innecessário, você submeteria esta paciente diretamente ao CAT, por exemplo, ou faria um estudo funcional primeiro? Estudo funcional, levante a mão. Agora está um pouco melhor. Então, a paciente foi submetida a este estudo funcional para confirmar a presença de isquemia, saber o monte de isquemia e estratificar o risco e conhecer, planejar o tipo de abordagem. Então, isto é que aconteceu no estudo de estresse. A paciente foi submetida a um exercício que alcançou 80% da frequência máxima calculada para a idade e aconteceu um infradesnível do segmento ST, nas derivações que vocês veem lá. As imagens da paciente após a prova de estresse. Vocês sabem que o traçador se injeta no momento do máximo estresse e vai indicar a distribuição do fluxo regional no momento da injeção. Após isso, passam vários minutos até que a paciente se coloca na máquina e as imagens são tomadas. Estas são as imagens conseguidas que mostram, acima está o eixo menor, e após isso está eixo maior vertical, por último, eixo maior horizontal. E mostra que é o estudo normal, levantem a mão quem pensa que é normal. É o estudo patológico, levantem a mão, estudo patológico. Estudo patológico de baixo risco, levantem a mão, o estudo patológico de alto risco. De alto risco tem um defeito de perfusão extenso na região anteroseptal e apical na distribuição da artéria descendente anterior. Agora, existe um problema aqui. Será que este é uma isquemia ou será que este é uma área de miocárdio hibernado ou será que este é uma área de infarto? Quem pensa que isto é um infarto? Uma necrose? Quem pensa que é uma isquemia? Miocárdio hibernado? E como sabe você que é uma isquemia? Que precisa para confirmar que isto é uma isquemia? Deveria conseguir uma informação de qual é a distribuição do fluxo no estado de repouso. Sim? Para conhecer como muda a perfusão entre a situação de esforço e a situação de repouso. Mas, neste caso, nós fazemos. Que outra informação você tem que leva a considerar que provavelmente este seja uma isquemia e não um infarto? Que outra informação tem aqui a fornecida até agora? Tem o eletro, não? Tem o eletrocardiograma basal. O eletrocardiograma não mostrava sinais de infarto. Não é totalmente sensível, mas provavelmente não tem infarto no eletrocardiograma basal. O eletrocardiograma basal era normal. E a alteração eletrocardiográfica acontece quando a paciente está sendo estressada. Então, com essa informação do eletrocardiograma e a informação da perfusão no estresse, com uma prova que consideramos de alto risco, a paciente foi enviada diretamente ao cateterismo. Não fizemos o estudo de repouso. E o cateterismo mostrou o seguinte, mostrou estas alterações severas da luz vascular no território da descendente anterior, é circunflexa, e a coronária direita. Sim? Então, este é um caso simples, bastante simples, que acontece para nós, acontece todas as semanas, temos algum caso parecido a este. Então, a vezes está a dúvida entre fazer o estudo de repouso ou enviar diretamente a paciente à hemodinâmica, não? Então, seria eticamente aceitável de dar um reporte de isquemia somente com estudo de estresse? Quem pensa que sim? Seria aceitável só dar laudo de isquemia somente com estudo de estresse? Deveria fazer o estudo de repouso para dar laudo de isquemia? Qual seria a opinião dos panelistas?
I personally would actually do the risk study also. I think you've got enough information probably that this patient is going to have LAD ischemia from the initial images and the ECG, but the risk study will help certainly down the track as well, because what you don't know what's going to happen is after you put the stent in, when the patient comes back in 3 or 4 months' time, and this information actually may be quite valuable, so you know what the baseline is. If you do the stent first and don't do a resting study, it may come back to bite you 6 months later.
Any other opinion from the panel?
Yes, the left ventricle is dilated and there's severe left ventricular dysfunction. So I think the rest study would be essential here to see if this is hibernating myocardium, infarcted myocardium, or reversible ischemia.
I have different opinion. Actually, with the basic ECG, there are mild T-wave changes. It's non-conclusive ECG changes. But we can image the patient without stress, inject the patient once she has chest pain and unequivocal or equivocal ECG, and we can see the perfusion at this phase. If it's ischemia, the ischemia is going on before the ECG is evident, quite evident, whether it's infarction, injury, ischemia. Here the perfusion can precede the ECG changes. It's the first step in the ischemia cascade. It's one of the advantages of doing rest study with a patient presenting with chest pain and ECG non-conclusive.
So Fernando, which one was the reason for not having the
Sorry, I don't hear.
the reason for not having the rest in this particular patient? Why you didn't do the rest?
Well, the reason was simply that that was a Friday. We usually
5 p.m.?
We usually perform a two-day protocol. So in that case, the patient would have to wait until the following Monday to have the rest study, and this is a very high-risk result. So we decided to send her directly to the cath lab.
So those are considerations that we always need to have in mind. So which one is the context of the image? This is extremely important.
But I have one more comment. We will use the CCT camera, which has much higher resolution in comparison to the traditional SPECT system. And therefore, you see more. And therefore, we do stress and rest systematically in all patients except patients with very, very, very normal findings. Because in also a small perfusion defect can disappear with the rest study using a high resolution system. But I understand the reason for doing the stress volume imaging in this patient.
Yes, I have another comment. I think this patient warrants immediate intervention. It's frank ischemic episode, and its large segment of the myocardium is threatened, it's jeopardized. Therefore, here the perfusion, it's indicative of urgent intervention. Whether you did the rest study post-intervention after 2 days, 1 week, you can get the perfusion status at the end of the episode. If it's successful revascularization, you will see how the perfusion improved with the revascularization, as the case I showed a couple of minutes ago.
Yeah, but in that case, you can perform also a stress study and see how perfusion improves at stress without the need of doing the rest.
Yeah.
In this case. Nathan?
I have one other trick that will work very well on a Friday afternoon at 5 o'clock. You showed on your study that the ejection fraction was 38%.
Yeah, 38.
Almost certainly that would be severe anterior hypokinesis with stress. You've already ejected your patient. You wait 15 minutes while you're waiting to go to the cath lab, image again, the perfusion will look the same, but the function would almost certainly have improved, and the ejection fraction would go up to 50%. You've in fact got like a mini stress echo, and you've got your answer.
I have a comment. Actually, when you have massive ischemia like this patient, the stunning may remain for a longer time. You need sometimes hours to regain the function.
So is there any comment from the audience about this particular case?
So the other question is, what should be ¿cuál debería ser la secuencia de los estudios? ¿Primero estrés y después o reposo o viceversa? Stress first or rest first? What would be preferable?
Yeah, I prefer in such case the rest study.
Pardon?
I prefer to start with the rest study. It's safer. Patient with query ischemic episode. ECG, it's not 100% normal. It's equivocal, and just the typical presentation. Cardiac biomarkers here may be beneficial, the troponin. It's just simple lab test, maybe of guide. But I think here, definitely, I like to start with the rest study for the safety of the patient.
Nathan.
But, it depends if you do the single day or dual day stress rest imaging. In single day, I think it's better to start with the stress study and then to do rest with the secularization for a very simple question, for radiation protection of the personnel. Because if you do rest first, you have to exercise a radioactive patient, and this is not good for the personnel.
The other thing is reimbursement issues. So, o tema do pagamento dos convênios. Não? Esta é uma razão prática para fazer as duas partes completas, ou em alguns países os convênios pagam por a resolução clínica do paciente, não importa se é uma parte, duas partes, três partes. Então, dá para comentar alguma coisa? Diana?
É um aspecto muito importante, porque em muitos países eles fazem o pagamento completo. Se você faz só estresse, eles não pagam o estudo. Então, também depende do lugar. Mas é muito importante aquilo que falou a doutora ALIA, da proteção radiológica. Não? Se você faz estudo de 1 dia, 2 dias, mas é muito importante fazer um ajuste da atividade que você está utilizando. As câmaras que o Dr. GIUBBINI utiliza, eles permitem fazer estudos com uma dose ainda menor. Então, muito importante de considerar.
Ok. Então, esta outra pergunta já foi mais ou menos contestada pelo painel, que eles estão a favor de fazer um estudo de repouso complementário. Mas eu somente queria mostrar um caso da prática diária e como a parte teórica, acadêmica ou a parte ideal muitas vezes se vê em conflito com o movimento do laboratório de uma clínica que tem que resolver os pacientes rapidamente. Neste caso, o paciente foi resolvido em forma bem rápida, somente com estudo de estresse, e então muitas vezes nós perguntamos a nós mesmos se um cenário parecido a este, com uma paciente que apresenta com dor na prova de estresse, que tem uma alteração eletrocardiográfica induzida por exercício e tem um defeito extenso de perfusão, esse paciente é enviado diretamente para o cateterismo, para o laboratório de hemodinâmica, vai ter 99% dos casos uma lesão significativa nas coronárias, vai ser resolta adequadamente. Obrigado.
Muito obrigada aos palestrantes e para vocês, e nós damos por terminada aquela sessão. Muito obrigada.